years because of the underlying issue with their valve disease and the right heart failure. So I'm going to show you two cases. This is the first one. 71-year-old female with carcinoid syndrome had previous tricuspid replacement, pulmonary valve replacement, and PFO closure at Mount Sinai in 2015, and now come back with severe prostatic TR and stenosis. And she could not undergo a repeat surgery because she actually had a hemodynamic instability during initial induction. This is the transthoracic echo showing the severe inflow acceleration with persistent stenosis and also TR as well. You can see here the mean gradient with 12 and peak gradient of 20. We use CT scan to evaluate these patients' valve anatomy because sometimes, despite on what it says on the operative note, you need to do CT scan to make sure they have the right anatomy for the right valve. You can see this patient has a small valve, it's 25 millimeters St. Jude epic. You can see here, there's a valve-in-valve app on the mitral side. You can download for free on your Android and iPhone. And you can use a mitral application, which is the same as tricuspid. You can see here, it tells you what the stent ID and internal diameter is and how the valve should be placed inside such a valve. And this is a particularly challenging case because you can see the epic valve has very little landmark, just a little sewing line at the annular level, which cannot be seen easily on fluoroscopy. And you can see here on the CT analysis, the area is around 390 millimeters square, perimeter 70, and the mean diameter 22, suggested we'll need a 23 sapien 3 valve. Then this app you can see here is created by Dr. Vinny Bapat from Colombia. Here's the deployment you can see here. This is the orange marker. You can see this is actually not that easy to see, and you have to really magnify to be able to visualize how it's done. And you can see here, this is done similar to a mitral valve-in-valve, where you have to make sure the valve is implanted in the correct orientation. We typically put the stiff wire in the right ventricle rather than the right pulmonary artery because it's more coaxial. And this is the final ventriculogram showing there's no TR left. And of course, there's no other issue as well. This is pre-implant under intraoperative TEE. You can see here the TR and the tricuspid stenosis. This is post-implant. There's no more TR. And you can see the gradient with 5 and the transthoracic echo home in 2 days. These patients dramatically improve and typically they go home next day or two afterwards. The case number 2 I want to show you is a younger patient with 55-year-old male, multiple hospitalizations, history of IV drug use on methadone, hepatitis C, and AFib with severe paraprosthetic TR. She had the initial tricuspid replacement due to endocarditis. Again, we use CT to remodel this anatomy. You can see this is a larger valve, 31 Hancock 2. You can see the mean diameter of this valve is around 30 millimeters. And you can see how it looks like modeling on 3D reconstruction on the Freeman Seal software. This is the TE. You can see here the patient has a lot of TR. This one has no stenosis, and which is see here as well with the 3D, basically torrential TR with no with primary leaflet failure. You can see again here as well. You can see how the echo can actually be helpful in positioning the valve. You can see on the 3D, there's delivery catheters across. And you can see here, you can how the position is relative to the tricuspid valve. And you can see here on the fluoroscopy that you have a landmark of the 3 dots. That's the commissurial post. And the ring, which is the annulars. And you can see we pass the pigtail again, crossing into the right ventricle. And this is the deployment here, looking at, again, making sure the valve's in the correct orientation with the stiff wire in the right ventricle. And you do a very, very slow inflation to make sure the valve takes time to become coaxial and deploy properly. Here's the final result. You can see here no more TR. You can see here in the 3D echo. And then you can see here the final fluoroscopy. This is the RAO view, and this is the LAO view showing the valve is completely circular against the prosthetic valve frame. And here's a transthoracic echo at discharge. So patient went home in 2 days again, no PVL, no TR, mean grade of 5, so very acceptable in these kinds of procedures. This is a third case I want to show you because this patient actually had the same situation with severe tricuspid regurgitation and stenosis. You can see here the hemodynamics. It's a 31 paramount valve, so we did a 29 sapien 3. However, this patient afterwards had no gradient, but then actually had a heart block unusually, and actually required a pacemaker. And of course, these patients, you cannot really implant a pacemaker in a classic traditional way. So we actually had a micro pacemaker, leadless pacemaker put in instead. And you can see here, it's very interesting what we call a bullseye sign, where the leadless pacemaker is in the middle of the tricuspid valve. So the tips and tricks is femoral venous access similar to the mitral clip. We use only one plug guide for the access enclosure at 12 o'clock. We then insert the Edwards E sheath. Then we then advance the Swan-Ganz or pigtail catheter in the right ventricle. If it's a stenosis patient, you might need to do a Swan-Ganz catheter because it might be difficult to cross. Then we exchange in a stiff wire. We then connect the pacing clips to the stiff wire to rapid pace if needed, but we typically do not need to rapid pace in these patients. We then insert the sapien 3 valve, make sure you check the orientation, cross the valve, and then deploy very slowly. And if you need to, you can use rapid pacing to stabilize the deployment. And afterwards, you can remove the system and close. Typically, post-op course, because it's the right-sided valve, we typically anticoagulate for 3 months if the patient can tolerate it. Usually, they can go home the next day, and you follow them up at 30 days, 6 months, and a year. So in summary, tricuspid valve-in-valve replacement is a safe and simple procedure to treat prosthetic tricuspid valve degeneration. The stiff wire in the right ventricle is the right PA, helps achieving coaxiality. During the implant inflation if the valve is not coaxial. Thank you for your attention.